you all to this Phaconightmares session, and the basic game plan is going to be very simple. We want to show various scenarios which you can manage and how to handle them step by step. So that's the game plan here, which I thought I'll show you all. Now, one technique which I thought I should start with, a thing which all of you can easily follow, is this one which I'm going to show you just now. And you can see here, this particular patient has got subluxated cataract. Now, what do you do when a patient has got such a bad subluxated cataract? Remember one thing. If this is a progressive condition, we do not put rings, we do not put MH segments or any of them. But if it is non-progressive, like a traumatic, then you can do this. And what we have got is this technique called the paper clip technique. So I'll show this to you in a second. You can see the subluxation present. Now do your scleral flap in the area of maximum subluxation. So you can see there, I'm making the flap in the area of maximum subluxation. Once we have done that, now the next step is I go ahead and do the rhexis. So far so good. Now, once the rhexis is done, slight amount of hydrodissection. Now watch carefully. We are making a sclerotomy under the scleral flap. So that's actually in the pars plicata. And from there it goes inside. Once it is done, we pass this paper clip capsular hook. That's made of PMA. Through the handshake technique, we catch the tip and we are going to bring it out through the sclerotomy. Now again watch carefully. This paper clip is like this. So it's got a PMMA intraocular device. It's made by Morture, and what it does is it has got a clip on itself which hooks on to the rhexis margin. So these are the dimensions of this paper clip, and once we do that, you will see me subsequently passing also capsular hooks, because what I'm going to do now is I need to stabilize that capsular bag. So I'm passing capsular hooks till the bag is stable. Once the bag is stable, this is the way I can catch this paper clip onto the rhexis margin. The advantage of this, when you compare to a suture technique or any other technique, is once you suture, you're in trouble. You have to open it. Here, you don't have to do that, because once this is clipped on, all we will do is put it into the intrascleral haptic pocket. So you can see that's a 26 gauge needle. I cut the extra amount of the paper clip, tuck the paper clip into the pocket there. And you can see me tucking it into that pocket. So now the capsular bag is stable. Once the capsular bag is stable, the two capsular hooks are also supporting the stability of the capsular bag. So now what I do is go in with my phaco, and you can see that nucleus is gone without any complication. Now once my nucleus is gone, the next step is we will have to attack the cortex. So you can see me just now going to do that. Remember one thing, you have given a radial support. I need to give a circumferential support also. To give a circumferential support, we just put an endocapsular ring, just like how you'll put normally. You can inject it inside any way you want, or put it manually this way. Once this endocapsular ring is in the bag, then we go in and remove the cortex. So now you can see now I've got the paper clip there, I've got the capsular hooks there, and I've also got the endocapsular ring inside. Once this is done, I don't need the capsular hooks. So I'm going to remove the capsular hooks, and once the capsular hooks are removed, I can implant a lens. You can implant any lens of your choice. We have implanted, in this case, a 3-piece IOL. One of the advantages of implanting a 3-piece IOL in such complicated situations is, if during the procedure things go bad, all we need to do is convert to a glued IOL. Since it's a 3-piece IOL, it will become very, very easy for me to do that. So you can see here, I'm implanting one haptic inside, putting the other haptic inside, and you can see the lens in place. Now once the IOL is in place, all we need to do is take off the viscoelastic and seal the scleral flap. So this is the fibrin glue which you are using to seal that flap, sealing the conjunctiva, and you can see how the patient looks at the end. Now the question comes, this is immediate post-operative. How did this patient behave? So let's see exactly how this patient behaves. Post-operative day 1. Already you can see a clear cornea. The vision has improved already to 20/20. And you can see on dilatation, you can see there clearly the capsular hooks present also. So you can see there the capsular hook, and this has been subsequently published in various journals. So the first thing I thought I'll start off with is on this paper clip. Now let's take this difficulty slightly to the next level. And what I thought I'm going to show you is another way to handle these type of subluxations. Now the problem is, when you get a bad subluxation like this is a type of Marfan's. Now the problem is, sometimes or most cases, these eyes are large. Now if the eye is basically large, there will be a small problem, and I'll explain to you why. Now these are progressive conditions. When someone has a progressive condition like this, please, I don't put any of these rings or segments inside, because 10 years down the road, they might lie on the retina. So what do we do? In such worst case scenarios, we will prefer to do the glued IOL. So let's see how it's done. First step, always measure. So you can see now, I'm measuring the large white to white. And you can notice, I will always go for the shorter distance. So here you notice the vertical 12 to 6 is shorter than the horizontal 3 to 9. If the vertical is shorter, please make the flaps vertically. Now how to make the flaps? Very simple. You can see I made 1 cut, 2 cuts and 3 cuts. So if I can get this laser pointer working, you can see I made 1 cut, 2 cut, and now I'll make the 3rd cut. And then from one side, pass my dissector, go out to the other, and just pull it out. So you can see now subsequently here, 1 cut, 2 cut, 3 cuts. Now I take this, and you will see me making that flap. It's a very simple way of creating a flap. It'll take you approximately about 10 seconds to make the flap. Cannot take you more. Now, one point remember, I have made my flaps vertically. See, 1 cut, 2 cut, and then the 3rd cut. Now all I do is start from one end, go to the other end, and once I'm gone out, I will just pull it out to the outside area. So you see there, and that's the flap completed. It cannot take more than 15 to 20 seconds. Now once you have made your 2 flaps ready, remember one thing. Wherever the flaps are, you have to sit 90 degrees from it. So if you see in this picture, the flaps were vertical. Now what I've done is I've rotated the patient, so the flaps are horizontal and I'm able to sit here. That means my clear corneal incision will be 90 degrees from the flap. If it is not, you will not be able to do the handshake technique. So now, next, always have fluid in the eye. Now when you have this fluid in the eye, remember one thing, you can use a retina trocar, or I can use a trocar AC maintainer. Today I prefer the trocar AC maintainers because it's above the iris. So it's very safe for an anterior segment surgeon, but remember, don't play this game with viscoelastic. Here I'm fixing my trocar cannula. Next step, I'm going to make 2 side ports. Remember one thing, I'm sitting now exactly 90 degrees from my scleral flaps. Next step, I'm going to do my vitrectomy, and you will see me subsequently doing some vitrectomy here. Now, small trick, what we are going to do here is this. I have a large eye. If I go 2 millimeters from the limbus to make my sclerotomy, the amount of haptic externalization is going to be less. Remember, all IOLs are 13 millimeters. They should actually be 14, but they have made them at 13 millimeters. So what I'm going to do is, I want to come more anterior. To come more anterior, simple trick, make a small iridectomy at the area of the scleral flaps. So watch this. You can see there, small iridectomy being made there. Once my iridectomy has been made on one side, I will make my iridectomy on the second side also. And you can see my second iridectomy made. Now why do I make it? I can come anteriorly, do a 22 gauge, remember the word, 22 gauge sclerotomy, about 1 millimeter from the limbus. It goes through the iridectomy. So see now, I'm going to go through the iridectomy, and I will come into the vitreous cavity. And you can see that's in the vitreous cavity, but it's going through the iridectomy. So it's absolutely safe. Now once I have got this, my vitrectomy probe can also pass through that, and you can see I don't need this lens. All it will do is give me more aberrations. So what am I going to do is, I'm doing a lensectomy, vitrectomy. I don't need it. It's a young child. Remember one thing, whatever you do on this child is going to make a huge difference for the life of this child tomorrow. And I'll explain to you why we do the glued IOL and why we are not doing other techniques. Now when you come near the iris, remember one rule, use aspiration, because you don't want to create an unnecessary iridectomy. Okay? Here you can see there I'm using aspiration, and Dr. Narang has published also the scaffold technique for spatula. You can use a spatula also to support it. But here in this case, I'm not going to increase my problems there, because I'm going to now implant the intraocular lens. So now, coming to an IOL, any IOL of your choice. My personal choice is to use an AMO lens, and I tell you why. It's acrylic hydrophobic, 1. 2, the haptics are very firm and sturdy. The Alcon lens is good. The problem is the loops are a bit not that firm. If you take the BNL, and I'm no financial interest with any of them, it's a silicone lens. So keep these facts in mind. I prefer the acrylic hydrophobic IOLs, especially if you are doing a PDEC or you're doing a retinal surgery, you don't want a silicone lens in the eye. Now remember, whatever lens you use, please use an AMO injector. If you see any of these other companies, the Alcon company have got a very good injector for single piece, not very good for 3-piece. So now, keep the haptic a bit out. Watch carefully. My glued IOL forceps has gone through the sclerotomy, through the iridectomy, and is now going to catch the haptic. So you can see the haptic now caught. Once my haptic is caught, please understand me, both my hands are stuck, because one hand has got the cartridge injector, the other has the forceps. Now what do? Ask your assistant to rotate. So you will see my assistant will rotate, wait for the lens to unfold. Nothing will happen to this lens. It cannot go anywhere. Why? One haptic you are holding. Second haptic is still out of the eye. But for heaven's sake, don't pull it out. Because if you pull it out before the optic unfolds, it can break. So you can see I'm waiting for the lens to unfold, then pull it out. Once my first haptic is out, now watch carefully, I go in and flex. So here you can do the no assistant technique, in which I'm pulling so much that I've gone inferiorly to 6 o'clock position. So this way, I don't even need an assistant. Now what I do is, my glued IOL forceps passes through the side port. Watch carefully, it catches the haptic. Now my first forceps leaves it, goes through the second sclerotomy, through the iridectomy, Now the game is simple. I need to catch the tip of the haptic. No hurry. Catch the tip. If it's my finger and I pull in the middle, it will break. If I catch it at the tip, I will be able to pull it out of the sclerotomy. How much time, please check, you have taken in this externalization of the haptics? It was not be taking more than half a minute per haptic externalization. If you take even a minute, the total duration, which is the key step, is haptic externalization cannot take more than 1 minute to 2 minutes max. And if you are taking more than 1 minute time or 2 minutes time, then please go back, check your surgeries videos and see where is the problem. Because they are very simple way. Now once I have both haptics externalized, now key factor which I want to show all of you is, see the amount of haptic externalized. Look at the amount of haptic externalized. Remember, I did come anteriorly. Remember that. I went through the iridotomy. I know this is a young child. I want this guy to be extremely happy even when the child is going to become an adult and old age of 70, 80 years. I need that haptic to be long because that haptic is going to go inside an intrascleral pocket. So once I have done that, I put my suture there. Now I create the Gabor-Chariot's pocket. So great technique started by this great man, great human being also, Gabor from Germany. And you can see there, Gabor pocket is being created. I created the tunnel, remember, with 26 gauge. And to be honest to you, even before Gabor had started it, Maggie had started this technique, but somehow it was given off. Then Gabor started it, then we took it to the glued IOL level. So now you can see what we are doing is we are tucking the haptic into the intrascleral pocket. And you can see there, how much do I tuck? As much as the haptic goes inside. And watch. You can see if the lens is getting decentered, that means you have pulled it too much. Now watch my left hand. So when you do this, watch this hand here, all of you. If you see my left hand is holding that sclera and this pointer light is not coming. So anyway, point is simple here. I'm holding that sclera there. If you have a good pointer, just give me one. Okay? I'm holding it because it's extremely important to be very solid in each step. Okay? Here you can see this is holding. I don't leave this. My right hand is tucking, my left hand is holding. This is my assistant holding the flap so that I have a good view. Tuck as much as you want. The game plan is simple. Can I center my intraocular lens? And you can see my lens well centered. Now once my lens is well centered, you can inject intraocular pilocarpine, make that pupil smaller. Now check. Do you have any captive iris? Remember, I came anteriorly. So the flip side is, you can get a captive iris. And if you get, we'll do a single pass photoplasty. I'll talk on it later. But here in this case, to make long story short, I don't have any captive iris. How do you know you're getting captive iris or not? Very simple way. Inject some air. At this stage, if you get captive iris, you'll get it. If you don't inject air and you still don't get captive iris, I can tell you, you will not get it post-operatively. Not that, frankly, the captive iris may make much of a difference, but if it goes to your neighboring surgeon, doctor friend who does not like you, he will take a photograph of that patient and show it to the patient. So, simple. I've got a round pupil, and look at the surgical time I have taken in this whole case. Now, I'm taking off my fluid, and I'm going to put in air. Why do I put in air? Because I want the area to be dry. When I started glued IOL, I had a case which I did very well. And next day I saw choroidals, kissing choroidal, bang on like that. It took me 1 month to make that patient all right with systemic steroids. And then I began to scratch my brain and think, what did I do wrong? Then I realized the surgery had gone well. At the end, I just switched off the fluid, put in the glue. I had an hypotony which I didn't realize. So bottom line here is, put in the air so that there's no hypotony. Apply the glue. Same glue can be used for the conjunctiva. So you can see there, the whole glue seals everything down. Now use the same glue for the clear corneal post-operative day 1. And you can see the iridectomy is also there, as I showed you, at vertical level, and that's pre-op. And look at the patient now, 2 weeks post-op, the vision has improved to 20/20. So basically, what I thought was to show you this second procedure, which is extremely important to understand. So what are we talking about now? We have a patient in which we have done the glued IOL. Now problem is, this was a subluxated lens, crystalline lens, or let's say aphakic, or if you have a PCR, you can easily manage these cases. But let's suppose an example comes where things are slightly, in a case, either operated by you or operated by someone else, in which you notice here a patient will have a subluxated IOL. So before that, I talked to you a bit about the trocar AC maintainer. Now look at this. This is designed by us, made by Mastel from the United States. This is like a retina trocar, but it is an anterior segment trocar. It is 25 gauge. Okay, it's very sharp, and you see here, it has got dusting on its tip also. So when I have a subluxated IOL present here, what I'm going to do is, watch carefully, I'm now going to open the conjunctiva, make my scleral flaps as you said, and here you can notice now, once my flaps are done and you know the game, now watch this. This is important for you all to see the trocar AC maintainer. I am now parallel to the limbus, and then I turn, and I am now created a valve, but remember, I'm coming above the iris. So far, so good. So what is my advantage here? The advantage is basic. I'm not worried about my retina space. I'm very comfortable where I am. Okay? Now what I do is, watch carefully, I do my vitrectomy. Now I already have a 3-piece IOL, luckily. If I have a 3-piece IOL, all I need to do is do the handshake technique. So I'm catching it one hand to another, one hand to another, till I catch the tip of the haptic. Once the tip of the haptic is caught, you can see here, I've caught the tip, caught the second tip here, both haptics are externalized. Look at the surgical time you have taken. The whole surgery will finish in less than 5 minutes. You make the flaps, do a little bit of vitrectomy, handshake technique, and you can see already the lens is well centered. All I need to do is take out my trocar AC maintainer, now inject intraocular pilocarpine, and you can see here, put in some air, seal everything down with glue. Question comes now, how did this patient behave? So let's see how this patient behaved at the end of the day, and you'll see me subsequently sealing this down, post-operative day 2, vision is already 6/9, and you can see pre-op, and you can see now the post-op of this same patient. Let's take this difficulty slightly more, okay? And this case was sent to me by one of the top doctors in India, Kapil Vora, and he is, as I call him, the Haryana Express. Suhas, Gaurav, come on top. So he is the Haryana Express, Kapil Vora, and this was a very big shot. He referred to me recently, and when I saw the patient, this is what I saw. It's a decentered IOL, but on top of that, it was a multifocal IOL. So now I was wondering, what do I do? So I measure and I see, is vertical better or horizontal better? Okay, so I decided, let me go for the shorter distance, and this is the epsilon marker designed by Ashwin, and you can see we are making the flaps here. The key is these flaps, they got to be 180 degrees apart. Okay, now watch carefully, I fixed my trocar AC maintainer, but now I have rotated my patient because I want to be in the 90 degrees to my flaps. Notice large eye still there, so I'm going to make my small iridectomy just like I showed you. But the key factor why I'm showing you this clipping is, It's a very small pupil. It's a very small pupil. So what am I going to do now? I'm wondering, how do I check what's inside? Iris hooks. Dilate. At this stage, please dilate. Don't struggle. What's going on inside? So I've dilated that pupil. I do my vitrectomy. I've got a decentered multifocal IOL. Catch. All I need to do is, I don't need to explant this lens. Watch what I'm going to do is, I'm going to do vitrectomy around the IOL so that I'm not going to externalize first. First, I'm breaking all the additions. Then I catch the haptic from one hand to another, and you see me transferring the haptics. This is the key. Handshake technique. Don't play this game with one glued IOL forceps till you catch the tip. Once the tip is caught, you can see now the haptic is out. Once my first haptic is out, all I need to do is externalize my second haptic. But the reason I'm showing you this video is not to just show you how to refix a decentered multifocal IOL. Another reason why I'm going to show you this clipping is, I'm going to take off this iris hooks and look the amount of haptic externalized. Watch carefully. Every case I show you, you will see the amount of haptic externalized is a lot, because I've understood that's where the game is. So I'm playing this haptic, tucking it inside, but I have a large pupil. I can center my IOL where I want it. So I not only have a large pupil, I definitely have a captive iris. That's a floppy iris, and a captive iris has gone. So now, if I send this case back to Kapil Vora, he is going to shoot me. So what do? I decided to do the single pass 4-throw pupiloplasty. And again, here you can see I'm now passing this. Now watch carefully. Okay? I'm passing the straight needle Prolene, catching the haptic, the iris from the other side through the paracentesis. Watch carefully. Now I go in through this. Now I'm going to railroad these two. You can use a 30 gauge needle also. Now once I have brought it out, the loop, watch again, first loop coming out. Once my loop is out, I'm going to pass 4 throws. So see that? 4 throws, now I pull it. But look at the mistake I've done. I've gone too central. And rather than making a decent pupil, I made it like a no pupil area. Look, it's already hitting this area. I should have been here. If I had been here, I would have been okay. But that's extremely too much. So now what do? No problems. What I'm going to do is, I'm going to do on the other side. So once I do on the other side, again you can see I'm going to show you the single pass 4-throw pupiloplasty. Then I will, once that's done, you can see here, I will open this first pupiloplasty with a simple way. I've opened it and I'm going to redo it. So basic bottom line here is simple. You can make it as much as you want. And to make a long story short, I have now got a well-centered multifocal IOL with single pass 4-throw pupiloplasty. Now saying that, can I have the audio please? I'm going to show you a video, and on this time this is going to go with audio, because to be honest to you, this has been submitted to the
SFT also helps in a mic. None of the producers have any financial interest in the products or procedures.
Just see this video with the audio.
Ten days ago, Ray was acquitted in a shocking murder that he committed. How then did he get away? Present day, Molokini Bar. I planned to take my AX50 rifle to take the life of my wife, but by mistake, shot the wrong person.
How did you get away?
Police, on further digging, found the cause of death to be glare.
Glare? What? How? Who? When?
Hang on. Let me explain. I had cataract surgery done a year back, and since then, I've been experiencing a load of glare.
Is it cataract surgery supposed to treat vision problems? Anyway, who did the surgery?
Surgery was done by a lazy old chap. He calls himself Dr. Vin.
How did you get away?
He did my cataract surgery all right, but forgot doing my pupilloplasty.
I don't get it. How did you get away?
Well, I then just told the inspector, had he done my pupilloplasty, I'd have shot the right person. The cops, the court, all bought my story. Poor chap. Dr. Vin got sentenced for not doing my pupilloplasty. All in all, no pupilloplasty means jail everlasting. There have been great innovations in the past with regard to pupilloplasty. Mechanal, seepsas, cerclage, and now we introduce an easy and novel approach called single pass fourth row pupilloplasty, SFT. Let's understand how this procedure is performed. Let's mark the iris before we begin. To any iris defect, there is a proximal iris where you enter and a distal iris where you exit. Step 1. Make a stab incision on one side of the iris defect. This can be the distal incision. Step 2. A 10-0 proline suture is passed from the opposite side. This can be the proximal incision through the proximal iris and left in situ. Step 3. A 26 gauge needle is then passed through the distal iris. Step 4. The needle of the 10-0 proline is passed into the lumen of the 26 gauge needle and railroaded to the distal incision and pulled through to the suture end. It's now important to understand the suture trail as it traverses the iris. The trail consists of 5 parts. Part 1. External to the proximal incision. Part 2. Proximal incision to the proximal iris. Part 3. Proximal iris to the distal iris. Part 4. Distal iris to the distal incision. Part 5. External to the distal incision. A loop of suture as depicted is taken from the part 2 of the suture, pulled out through the distal incision and made to lie on the conjunctiva. The part 5 of the suture is now cut and the cut end is thrown into the loop of part 2 4 times, hence showcasing the 4th row of this pupilloplasty. Now, to tie the iris defect together, we take part 1 and part 5 of the suture pass and pull them away from each other externally. This pull brings about a helical pattern to the 4th row knot. Now, as the knot approaches the iris defect intracamerally, it brings the 2 sides of the iris defect closer. Finally, when the helix of the knot comes in contact with both the proximal and distal iris, intertwines it all together to complete the knot. Now a micro scissor is taken and the suture cut close to the knot, thereby completing the single pass 4th row pupilloplasty. Indications of SFT: in appositional closed angle glaucoma, in Uretz-Zavalia syndrome, in pupil reconstruction, in endothelial keratoplasty, in intrascleral haptic fixation. Effects of SFT: lowering intraocular pressure. SFT lowers intraocular pressure. Reports in the past of reduction in intraocular pressure from breakage of pre-existing peripheral anterior synechiae have been documented. In cases such as appositional angle closure glaucoma, Uretz-Zavalia syndrome, SFT pulls the iris tissue closer to the center of the pupil, allowing the aqueous to flow freely through the meshwork, thereby breaking the pre-existing peripheral anterior synechiae and opening up the angle as shown in this before and after intraoperative gonioscopic view of the angle. SFT has shown to reduce the intraocular pressure in this 9-month study of closed angle glaucoma and Uretz-Zavalia syndrome. Laser peripheral iridotomy is the treatment of choice in case with primary angle closure glaucoma associated with pupillary block. However, often the formation of peripheral anterior synechiae continues even after a successful laser peripheral iridotomy. Performing an SFT has shown to have a dramatic change in these cases. The nomogram used in cases with more than 270 degree synechiae we recommend performing a 6-point traction. In cases with less than 270 degree synechia, a 4-point traction suffices. SFT compartmentalizes the eye. In compartmentalizing the eye, SFT separates the anterior and posterior compartment. SFT helps in endothelial keratoplasty by preventing the air injected from escaping into the vitreous cavity, and also forms a diaphragm that helps thrust the air bubble towards the graft, ensuring graft attachment. SFT also helps in intrascleral haptic fixation by preventing an optic capture. It acts as a mechanical barrier to the optic edge and thereby reducing the tilt change in the shape of the pupil. SFT changes the shape of the pupil. In cases such as traumatic mydriasis, iatrogenically caused large pupil, and congenital conditions, SFT has a profound impact on quality of vision. It reduces glare, halos, improves the sharpness of vision, eliminating diplopia, reduces photophobia, creating a pinhole effect to vision. Advantages as a pupilloplasty technique. The single pass is a game changer in pupilloplasty for these reasons. The number of times a surgeon enters the eye is inversely proportional to the ease of doing a pupilloplasty procedure. A surgeon becomes more efficient by performing more numbers of sutures than passes, closing the iris defect faster. SFT allows the pupil to dilate post-operatively. The amount of dilatation is inversely proportional to the iris manipulation, which seems to be the least in this procedure. The knot forms a helical pattern that lies flat along the iris plane and doesn't bulk up like in other procedures. This prevents rubbing of endothelium in endothelial keratoplasty. All in all, SFT is a great procedure and a must-know, must-have in your surgical armamentarium, owing to reduced number of passes, ease of suture tying, reduced iris manipulation, increased dilatation post-surgery, and improved repeatability.
So thank you very much, ladies and gentlemen. For this, basically, I will have to give two people credit for this work done. Primarily is perhaps Dr. Narang, who helped me a lot on this single pass, and Ashwin made this video also. So now I thought I'll show you, let's take this difficulty slightly more, okay? And then we'll show some jing-bang stuff also for everyone. But important for us all to see is, can we take this difficulty slightly more in the case which I'm showing you? Now this particular patient, let's see how it goes. Okay, this is the patient. This was a general from Ghana, and believe it or not, he was a top general. And he flew down. I have a hospital in Ghana, but I said, listen, send this patient to me because this is a very tough case. And he came with an ophthalmologist. And believe it or not, when I saw him and he went out, my staff and doctors came to me. He told the doctor who had come with him from Ghana, I'll beat you if my eye doesn't become all right. This guy had gone to America and got an surgery done, and there an ACIOL was implanted. Notice carefully, there is bad scarring here. So I can't see what's going on, but there is an anterior chamber IOL inside the eye. So now question comes, what do I do? I make my scleral flaps, okay, I make my scleral tunnel, and all this time I'm wondering if this Ghana top general has beaten the ophthalmologist, what will he do to me? I'm wondering if I go mess up the case. So I'm now taking off this bad scarred epithelium, and I see an anterior chamber IOL, and you can see it's a mess. So I make my sclerotomy, 22 gauge sclerotomy, 1 millimeter behind the limbus. Now what I'm going to do is, obviously I have to do some vitrectomy. Remember, if you are trying to explant, first do vitrectomy behind it. And I always go back and check because I do not know what the surgeon had done before. So I'll always do a posterior vitrectomy also. Now my next step is I need to take out this ACIOL. And remember, these IOLs above the iris are a mess. Because what happens is, it messes up the iris. When you're explanting them, they can bleed. You can get an iridolus, and you look at that. It's stuck to the iris. So I have to be very careful I don't mess up this area. I make my scleral tunnel incision. Don't make a clear cornea because it's a large incision, 6 millimeters. Make a scleral tunnel. Look at that iris coming off. my heart is also coming off at the same time. Okay? So I have to be very careful when I am removing this ACIOL. Notice an assistant always uses an endoilluminator. So they use an endoilluminator to help me see better. ACIOL gone. Once ACIOL is gone, I have a large incision. I can put that lens like a foldable, non-foldable IOL, catch one haptic, externalize, flex the second haptic, transfer it to my second forceps. All this already I have shown you people, so you know the game now. Catch the tip of the haptic, externalize, cannot take more than 1 minute to externalize both haptics. So far, so good. Watch how much haptic is externalized. It's quite a lot. I'm happy. Suture the scleral wound, create the Gabor Chariot's pocket, and tuck it inside. Case not over. Now, I've just done my ACIOL explantation. I've done my vitrectomy. I've done my glued IOL. Now remember, single pass, 4th row pupiloplasty. 1, there is peripheral anterior synechiae. I'm going to bring that pupil down. I'm going to make it small. So my angles are going to open, the intraocular pressure will become bang on track. Second story is, I'm going to prevent my air going back. It will remain inside. And the glued IOL works like a trampoline. So watch carefully now. I'm now going to do my single pass 4th row pupiloplasty, straight needle. Now you know this game very well. Pass it from one side, catch from the other side, pass a 26 gauge or a 30 gauge needle, choice is yours. Railroad the two, single pass. Remember, every time you do a pass in seepsers or McCannel, every time you have chances of damaging IOL, iris or endothelium. So the single pass makes a big difference. And then number 4. You can try 3, it will open. 5 is just not needed. So 4 is pretty sufficient. That's why we chose the number 4. And you can see, just pull it. It's so simple. Monday morning, any of you go back, believe me, post a case. Single pass 4th row pupiloplasty, you will love this because it's so easy to do. Look, I'm going to make that pupil small, okay? Once my pupil is small, now watch. I'm going to fix a trocar AC maintainer. So I've got fluid in the back. I've got a trocar AC maintainer in the front. This will give me air. The one in the back is pushing my iris IOL diaphragm anteriorly up. Because the problem, remember, why do people struggle in vitrectomized eyes? It is to unroll a graft. Because you get a deep anterior chamber. In this case, you will not get. So now, I'm just going to take my PDEC graft. Remember that? It's a PDEC graft injected inside. So this has got desmase, endothelium, and the pre-desmase layer. 1 minute I have to explain to you. 3 endothelial keratoplasties, all of you. DSEC, DMEC, PDEC. Believe me, you don't even have to be an ophthalmologist to understand which is better. In DSEC, I'm taking 100 micron tissue. So if a 500 micron cornea is there, I'm putting it on an endothelium, it becomes 600 micron. Does not make sense. In DMEC, I'm taking 15 micron, putting it, very good. What is the problem? My desmase is stuck to my stroma till the age of 40 or 50. That means basically, if I need a DMEC tissue, I need to tell the eye bank, give me a 50-year-old man, 60-year-old man. They are diabetics. They don't have that good cell counts. So in PDEC, it's 25 micron, but any donor age. Once I have this, I now will unroll my graft, and you can see my air continuously infusing inside the eye. Now the question comes, how did this patient behave? Look at the patient now, 1 week post-op, and you can see how the patient is looking pre-op, post-op, 1 week only. 3 weeks post-op, patient's vision is improved to 624, and 3 months post-op, the patient's vision is already improved to 6.9. And remember, he was going to beat up the ophthalmologist. I was wondering what he was going to do to me. That was a bigger problem for me rather than anything else. Now that I've shown you this much, what I thought was, I need to show you something new. And this is extremely important because some of you might have heard about it, but that's hypersonic vitrectomy. So basically here, we were the first to do hypersonic vitrectomy in a human eye. So they had flown down the entire Bosch and Lomb team. And remember, the shocking here is that you're going to use ultrasound to remove vitreous. Actually, it's shocking. So this is the Vitesse and Stellaris Elite probe, and I was the principal investigator for this. And you can see here, this does cuts at 1.7 million. Please remember, a normal guillotine cutter which we use does at 5,000 to 16,000 cuts. Now what we are doing here is, you're using the ultrasound to liquefy the collagen and make that into water. Now the point here is, look at the picture here on the left and the picture on the right, and that's 10,000 frames per second. And you see the guillotine cutter vis-a-vis the hypersonic vitrectomy cutter, and you realize there is no traction in the hypersonic vitrectomy cutter. So now, let's see how this looks. Remember this patient? PCR rupture. This is the first human eye ever done with a PC rupture using hypersonic vitrectomy. You know the basic steps here, but let's see how it works with the hypersonic vitrectomy. I fixed the trocar AC maintainer. I'm going in with my vitrectomy probe, and I'm knocking off this vitreous. Now remember, there is some nucleus present there also. The same Vitesse probe, the same hypersonic vitrectomy will remove the vitreous, can remove the nucleus. I'm not bothered which is vitreous or whether it's nucleus. If I'm doing a phaco, then I'm worried. Here, I'm just not worried. So once I have done that, I take this 22 gauge needle and I'm going to bring this nucleus anteriorly. Once I have brought it anteriorly, this is the modified PAL. So once I have brought it up anteriorly, watch the next step. I'm now going to inject the IOL. Inject a 3-piece IOL, always. So I've injected above the iris, under the nucleus. This is the second part of the triumvirate, which is the scaffold. So now, the same hypersonic vitrectomy, 23 gauge probe, I'm going to use to knock off the nucleus. The advantage here is, in hypersonic vitrectomy, there's one probe. In a normal guillotine, there's one inside another. So I can't go small. Actually, in this, I'm using a 23 gauge because this was the first prototype. But we can go smaller. Nucleus gone, now dilate. So now I'm dilating the pupil with iris hooks. Now I go in with the same hypersonic vitrectomy probe, and you can see me removing the vitreous, removing the cortex. And that's so comfortable because I can go through the same pars plicata incision, and once I have done that, I can attack any piece. So if I have nucleus, I have no problem. If I have vitreous, I have no problem. If I have cortex, I have no problem. I can shift from ultrasound to aspiration, back to ultrasound, all depending on me, on my foot pedal control. So you can see here, I'm removing the subincisional area, and I'm going to go in from the other side also. Look at that. The same Vitesse pros goes through the 22 gauge sclerotomy, subincisional area, and I can knock off this whole stuff behind. So there you can see, I'm knocking it all off, and once I removed it, look at my surprise. I found a nucleus piece behind the IOL. Now what am I going to do? I'm going to bring this fellow above the IOL. Once it comes above the IOL, I'm going to use that as a scaffold, and I'm going to take it off again with the same hypersonic vitrectomy. Once I have done the anterior portion, I pass an endoilluminator. The same thing, I go behind and I'm doing a posterior vitrectomy. Some fragments are there, I can knock it all off. So this, I thought you need to see how one is using hypersonic vitrectomy. Check disc, check macula, it's game, set and match. Now all I need to do is shift my IOL, which is above my iris, to behind my iris. I've shown this to you before. All I do is handshake technique, transfer it from one hand to the other and shift it. So you can see the haptic moving from one hand to the other, catching the tip of the haptic, pulling it out. Once that's done, watch, I'm going to do it from the other side, pull it, the second one out. Once both are out, now you can see I'm very comfortable. Take out my iris hooks, do some vitrectomy around this area, create my gauche area pocket, and now you know this full game thoroughly. Now all I need to is take out my trocar AC maintainer, put in air, and seal everything down with glue. The question comes, how did this patient behave? Because remember, this was the first case done. That's post-operative day 1 week post-op, and ladies and gentlemen, you can see 1 month post-op of this same patient. So once I have shown you this, I thought I should show you. Let's see a little bit of jing bang stuff. Okay, and we have Gaurav, Luthra and Suhas also to show us their various cases. And I thought I'd show this to you, how to manage small pupil. So this was a case which had small pupil, and this is an eye ring from Beaver Visitech. So you can see that it's made of polyurethane, okay? And I'm injecting it inside, so far so good. And this was a patient who had a mature cataract, and I am a bit colorblind also. So I thought, let me put trypan blue, but notice carefully, I have missed C. I have not completed the rexus. I mean, I'm bad surgeon, but here I'm dumb also. So I've not seen that also. Now I continue to do my phacoemulsification. And when I go in to do my phacoemulsification, watch carefully. Obviously, my rexus has extended. And now I suddenly realize it is gone. Now at this stage, what you can do, either I can call Gaurav or Suhas and tell them to help me. But these guys are far off and extremely busy, so they don't come. So then you do the second best thing in life. Start praying. Okay? So I start praying and I'm hoping something will come with that nucleus coming up anteriorly. But obviously it's not going to come. And I've got an eye ring inside that eye. So I fix my fluid in the eye. I do my vitrectomy. And now watch carefully. I've removed my cortex. And there my piece is still there. I made my flaps. Remember, I'm still praying here. But it's still gone down again. So I continue praying here and hoping. Luckily it comes. Once my piece has come, I catch it. Now remember, I have to bring it above my eye ring. Once it is above the eye ring, I now do a scaffold which I've shown you before. So now I'm going to inject the 3-piece IOL. So it goes above the ring, behind the nucleus. Now I have my scaffold, my posterior capsule in place, and I can do my phaco. And before you can say, bingo, that nucleus is gone. Now the problem is, I told you, I have to transfer from above the iris to below the iris. The mistake here is I did not realize I have an eye ring. So now watch what's happening. I'm trying to transfer it. It is getting locked onto the eye ring there. Watch that. It's got stuck there. Now I'm getting stuck in style there. So now I'm trying to bring it and I've lost my haptic. So now at this stage, one haptic is in the vitreous. Now I'm going for my second haptic. So you can see now, I'm doing this vitrectomy there, catching it, and I'm pulling it out. So far, so good. But remember, the first haptic is still in the vitreous. So again, I do my handshake technique, and I'm catching it, and I'm going to bring it out there. Once the haptic is out, you see there, both haptics are out. Now I have to remove the ring. Now watch carefully. When the ring has to be removed, first dislodge the ring from the iris. Then go in and remove it. I have not done that. I told you I was dumb. See, I'm trying to just straight away remove it without dislodging it and see what happens. Boy, oh boy. So now you see why nobody wants to assist me. Okay? So now I'm in a mess here because I've created an iridodialysis. Now in the bargain, I am now trying to dislodge this from the iris. And you can see I should have done that before. Once I have done that, now notice carefully, I'm going to try to remove the ring. But this ring, instead of coming north, is going south. It's sinking. And with the sinking, watch my haptic here is going down more and more. And I'm losing my haptic. So, the haptic has gone. My assistant is running for it. I've caught that ring so that it doesn't drop down. Brought it up anteriorly. Now I'm going to go in and remove this eye ring with the injector. And you can see me doing that just now. Once that comes out, I have to redo my haptic. because I was a bit posterior. So I'll make an anterior sclerotomy, re-internalize my haptic, re-externalize it again, and get more haptic externalized. So far, so good. But remember, I still have an iridodialysis. So what am I going to do now is fix back my iridodialysis. So here you can see I've created this 26 gauge needle, tuck the haptics into those pockets like I've shown you before million times today itself. Now suture the posterior sclerotomy. I don't need to keep it open, though I'm going to glue it, but it's better to seal everything down. Now pass my area so that I can put my iridodialysis, fix it back inside there, put in air. Now the question comes, how did this patient behave? You can see the final portions with the glue, and that's post-operative day 1. And now look, finally, ladies and gentlemen, how this patient behaves at the end. 2 months post-op, patient's vision has improved to 6/6. So basically, ladies and gentlemen, I thought I will show you various scenarios in which I've shown you scaffold, glued IOL, hypersonic vitrectomy, single pass photoreoplasty, and various other worst case scenarios. But the basic game plan is to show you how to manage various scenarios. So thank you very much, ladies and gentlemen. I request Gaurav Luthra to please come here, and while he's setting up his system here, if anyone has questions, who has come on top? If anyone has any questions, let me know. Otherwise, anyone any questions? Otherwise, I'll ask people, like, let's say Suhas is here. Suhas, what is your opinion? Let's give an example, if you take the mic there. You know, when you are doing the glued IOL or you are using iris claw lens perhaps, which technique do you prefer? You're using the iris claw?
Yeah, it's a matter of someone who's comfortable with.
Yeah,
I use iris claw.
Okay, now Suhas is using iris claw. So the question comes very simple. Let's ask ourselves, why should I use this, a glued IOL? All of you have these iPhones. When you're ready, let me know. Huh? All of you have iPhones. There's a simple app in this called Slow-Mo or Slow Pro. These videos which you see are at 25 frames per second. The Slow-Mo takes at 250 frames. Take an iris claw lens, let's give an example, put it on a video and take a video of it and you'll see the lens moving. That's one problem. We made a video also called Purkinje images. Now I'm not showing it to you, but you know Purkinje is 1, 2, 3, 4 are there. So if you measure Purkinje 1 and 4 on a movement, you'll see a lot of movement. These are just some few points which I suggest to tell you people. Another question I want to ask you is, you're using the sewing machine technique for iridodialysis. I didn't show that, I hope you show it, but what is your opinion on the sewing machine technique?
Well, I mean, if you have a giant dialysis like that, where you want to have suturing in continuity, probably that works good. But like the dialysis you showed here, even one suture is good enough. So
it's a very good point. Anyone, any more questions? Okay, so we'll do one thing. Let's move on to Gaurav Luthra and then we'll come back to Suhas and some more questions. Gaurav, all yours.
Thanks, Dr. Amar.
यहाँ जाना, यहाँ जा. Just so that everybody can hear the question, Gaurav.
Previously, we used to do a sclerostomy a little behind.
Yes.
And now you moved ahead
Anterior.
because you got the PI and
Yes.
that assists you
Correct.
making a 13 mm lens.
Correct.
So now you are saying 1 millimeter is enough for your sclerostomy?
Yes. Normally, now what I do is, if you go too far back, simple principle I'm telling everybody, okay? Let's take this as the haptic, okay? And this is my opening. I have brought out this much, and it's quite a lot. Then you have got enough haptic to tuck, because the strength of the glued IOL is here, okay? Let's say it was this much only. What I will do is, I will come more anterior. If you come more anterior, the problem is you'll hit the iris. If you hit the iris, you'll either create a bleed or you'll create a dialysis. So make a small iridectomy so that I can come more anteriorly, 1 millimeter. This will become this much. So re-internalize, re-externalize from the anterior sclerotomy, and you're on track.
So the difference I find is that your haptic externalization has huge volume of haptic.
Yes.
And that's assisted you more.
Yes.
Only another last question is, your PI is at 12 o'clock.
One second. Before you ask the second question, I'll just add one caveat to that. The second game which has changed, and I'm being very honest to you from heart, I'm telling you people, single pass photoreopuplasty, because when I come anteriorly, I can get a captive iris. Today what I do is, I tell you, I don't even think, yaar. If I see a captive iris, tuck, tuck, 2 minutes it takes, finish it. But those patients go damn happy.
The last is you've done 2 PIs, one at 12 and one at 6.
Correct.
So the 6 doesn't interfere at all in the quality of vision.
No, it won't interfere, because anyway you do it. It's a small one.
One small.
It's a very small one. Even then it doesn't interfere. You know, if we do it in, let's say, silicone oil or something, we are doing it. It's too small. Okay?